Hello everyone. Today we are going to start with a new topic which is clinical features and tests for malabsorption. So will you evaluate that there is a malabsorption? So it will be like Instagram, there's two-step verification on Instagram. So here the same way there is three-step verification. You have to confirm first the diagnosis. Second, you should confirm whether it is global or selective malabsorption. And third, you should confirm the etiology. So how you will confirm the diagnosis? Diagnosis you will confirm with the help of tests, various tests like Ship's test, Selling's test, fecal fat test. Various tests are used for confirming the diagnosis. And how you will differentiate between global malabsorption and selective malabsorption. In global malabsorption, majority of nutrients are affected, like fats, carbohydrates, protein, minerals. Everything is malabsorbed. But in selective malabsorption, only a selective part is staying unabsorbed, such as only the fat is not absorbed or only the carbohydrates are not absorbed. So that is selective malabsorption. Global malabsorption has its own diseases and selective has its own diseases. Now we will see what are the scenarios. If there is malabsorption inside the system, it will not only affect the GIT, but it will affect the other systems as well, such as the musculoskeletal system, cutaneous, everything. If the vitamins are not absorbed, it will appear on your skin. So cutaneous diseases will be there, and some miscellaneous diseases we will be going to see in this thing. So what does this chart explains? First is osmotic diarrhea. In GIT, what it will cause? Osmotic diarrhea. Malabsorption of fat will lead to osmotic diarrhea. It is a chronic type of diarrhea. We know it occurs in small intestine. If the duration is more than 4 weeks, then it is chronic diarrhea. The osmotic gap is larger in this and it improves on fasting. And that all we have seen in osmotic diarrhea. If the fat is malabsorbed, it also leads to steatorrhea. Steatorrhea is the hallmark of malabsorption of fat. What is steatorrhea? I have told you, passing of malodorous, foul smell, greasy stools, oily stools in bulk. It is known as steatorrhea. Then there is carbohydrate malabsorption. If carbohydrate is malabsorbed, so it will get fermented inside the small intestine and it will release gases such as methane, carbon dioxide, and hydrogen, which will lead to abdominal bloating and dysphagia. Then, if there is protein malabsorption, what will happen? There will be foul smell because this protein is also fermented inside the small intestine. There will be ascites, means filling of fluid inside the abdomen, and there will be edema. Edema refers to swelling, and then there will be unexplained weight loss. You cannot explain why the patient is suffering from weight loss. Then, when you do the tests and you get the confirmation that okay, there is malabsorption, then you can explain that okay, this was the reason that the patient was suffering with weight loss. Musculoskeletal, it will affect the musculoskeletal if the fat is malabsorbed. If the fat is malabsorbed, there will be decrease in the absorption of vitamin D3 and calcium. Okay, fat is malabsorbed, but why the vitamin D3 is not getting absorbed? Vitamin D, sorry about that. Vitamin D. So the vitamin D is fat soluble vitamin. If the fat is malabsorbed, vitamin D won't get absorbed. And why the calcium is not getting absorbed? So the fat which is malabsorbed, it will stay inside the small intestine and it will bind with the calcium atoms. It will bind with the calcium atoms and form soaps. And this process is known as saponification. Now, if the soaps are formed, so eventually the calcium will be unable to get inside the blood and it will lead to tetany, fractures, bone pain, as well as osteoporosis because there is calcium deficiency. Then there is cutaneous. In cutaneous system, what happens? If the vitamin B3 is deficient, it will lead to hyperpigmentation as well as it will lead to pellagra. Pellagra causes dermatitis, diarrhea, dementia. And then there is vitamin C3, vitamin C deficiency. If the vitamin C is deficient, it will cause perifollicular hemorrhage and curly hair. What do you mean by perifollicular hemorrhage? You will see blood near the hair follicles. Beside the hair follicles, always there will be a little clot. It will be like this appearance, dot blood. You will see. So that is perifollicular hemorrhage. If the vitamin K is absent, vitamin K, it is majorly responsible for clotting. It is there. If it is absent, it will cause bruisability and ecchymosis. Bruisability means if someone hit you on the palm, on the cheek, you will find red color appearance there. That is formation of bruise because the blood gets clot at that area. So that is bruisability. If zinc and folic acid are deficient, it will lead to acrodermatitis. What do you mean by acrodermatitis? It has like three symptoms it contains. It contains diarrhea, dermatitis, as well as alopecia. This acro word means alopecia here. There will be hair loss. If the vitamin A is deficient, then you will see follicular hyperkeratosis. There will be formation of large amount of keratin near the hair follicles, inside the hair follicles, and new hair follicles won't be able to grow, and the first hair follicle which are formed, they will get degenerated after this hyperkeratosis, and the person will suffer with alopecia. And there is celiac disease. In celiac disease, growth will be retarded. There is nothing to explain here. Then miscellaneous concepts. Vitamin B12. Vitamin B12, it is the most important vitamin because it helps in the maturation of RBCs. Everyone should know this. So if the vitamin B12 is unabsorbed, it will lead to anemia. There are various types of anemia like pernicious anemia, megaloblastic anemia, macrocytic, microcytic. It is a big chapter. So if there is malabsorption of vitamin B12, it will lead to anemia. In proximal part, if the folate, which is vitamin B9, and iron is deficient, it will lead to iron deficiency anemia, and folate will, if the folate is deficient, it will lead to megaloblastic anemia. Vitamin B12 deficiency also leads to peripheral neuropathy, ataxia, glossitis, ileosis, and stomatitis. What is peripheral neuropathy? In peripheral neuropathy, the peripheral nerve will be affected, they will be malfunctioned, and in ataxia, there will be no coordination. If you send the signal from the brain that you should lift your right hand, the brain will lift the left hand. There will be no muscle coordination. That is ataxia. Glossitis means the glottis is getting irritated. Scoliosis, there the tongue is getting affected, and stomatitis, there the lips are getting affected. We are getting just an irritation because the vitamin B12 is deficient. If the vitamin A is deficient, it will lead to night blindness and xerophthalmia. In xerophthalmia, the cornea and the conjunctiva gets dry. So you will find an itching sensation inside your eyes all times. And night blindness, it is a common symptom if there is the deficiency of vitamin A. Then kidney stones. How does this kidney stones form? I'll tell you the formation. In normal physiology, what happens? Whenever we eat substances like spinach, peanuts, they get inside our body, it contains oxalate. This oxalate moves from the small intestine and it combines with the calcium, forming calcium oxalate stones, and it will be defecated. So that's a very simple thing. But what happens? There is malabsorption of fat. So if there is malabsorption of fat, fat is being getting this saponified with calcium ions and forming soaps. Now oxalate is coming there, and oxalate is seeing that there is no calcium left inside the small intestine. So it will move on to the colon for getting outside the body. But in colon, what happens? The colon absorbs oxalate. When the colon absorbs this oxalate moves inside the bloodstream, and in the bloodstream, the blood will get panic and it will say, okay, we have to excrete this. This is a form that cannot survive inside the blood. So they will send this oxalate inside the kidneys, and whenever this oxalate goes inside the kidney, it will find calcium there, and it will bind with the calcium, forming calcium oxalate stones. These are hard stones, and they are like very large. If they are large, they are we will be unable to pass them. But if there is small size like 3 mm to 4 mm, or maybe 6 mm, till 6 mm it can get out of the body, but not more than that. If it is more than 6 mm, like 8 mm, 12 mm, it should be removed surgically only. So note what is the note given here? Symptoms not seen in malabsorption: abdominal pain, and constipation, and fever. In malabsorption, you will majority see diarrhea, not constipation. This is not a symptom of malabsorption. Abdominal pain, if it is okay, abdominal pain will be there if it is a large intestinal diarrhea, but not due to malabsorption. It is due to bacteria which are invasive, like Shigella, Viamla, and fever. Fever is not present in malabsorption. So, differentials of malabsorption. Some of the diseases are there which mimics this symptoms of malabsorption, like TB and nephrotic syndrome. Nephrotic syndrome, basically there is protein loss, albumin and globulin are lost. And in TB there will be weight loss, long-standing diarrhea, edema, ascites. These are all symptoms of malabsorption, but we can see these symptoms in TB as well. So never get confused between TB and malabsorption. Investigation. So okay, you have seen that this is not this is malabsorbed, the fat is malabsorbed, carbohydrate is malabsorbed. But how you will diagnose? How you will test that? Okay, the fat is only malabsorbed. So there are two tests for identifying the fat malabsorption. First is the quantitative test, and then there is qualitative test. In quantitative test, we have Sudan 3. It is a stain. This stain will tell you whether the fat percentage inside the stool is positive or negative. And then there is quantitative test. Quantitative test, here is the fecal fat test, 72 hours fecal fat test. It's 72-hour fecal fat test. It is a gold standard test. Majoritarily, we use this test for identifying what happens in this test. I will tell you. Like we will feed the patient for 5 days with 100 gram of fat per day. And from the third day, we will start testing the stool sample. And in stool sample, if there is fat percentage more than 7 grams per day, so we will tell that okay, the person is suffering with malabsorption of fat. If it is less than 7 gram per day, then the person is not suffering. The test is negative. Fecal fat excretion test is the gold standard investigation for malabsorption, as I have told there. For carbohydrate metabolism, carbohydrate malabsorption, we will have this test called as D-xylose test. This is the best and the most specific test for D-xylose. What does D-xylose consist of? D-xylose consists of pentose monosaccharides, and this D-xylose, what are the steps with which we will identify the test that the carbohydrate is getting malabsorbed. So first of all, we will feed the patient with D-xylose, as you can see here. 25 gram of D-xylose is given orally after fasting. Early morning we will give this, and after giving this, we will take the urine sample. We will collect the urine sample after 4 to 6 hours and check the D-xylose level. If the D-xylose level are more than 4.5 gram, then we can interpret that the patient is normal. And if it is less than 4.5 gram, we will interpret that the patient is suffering with small intestinal mucosal pathological condition. And we can say yet an inference that the patient has malabsorption of carbohydrate. It will lead to some diseases such as lactose intolerance. False positive of D-xylose tests. In which condition you will get the D-xylose test? False positive. In renal failure, because there is defective excretion. So in urine test, you will get with the carbohydrate, you will get a lot of substances. You will get proteins as well. So you will misinterpret this. Rapid intestinal transit. If rapid intestinal transit means the bowel movement are increasing here. If the bowel movement are increasing, the food is unable to stay inside the intestine for a longer duration of time. If it is not there for a longer duration of time, the substances won't get absorbed inside the intestine. And if the substances are not getting absorbed, so you will say that it is the malabsorption of carbohydrate. It will also show you the false positive. SIBO, small intestinal bacterial overgrowth. The organism utilizes these hydrolose and reduces its absorption. So then also you will get this false positive. Ascites, sequestration of D-xylose into third space, and it will also reduce absorption. Then there is lactose tolerance test. This lactose tolerance test is generally not used nowadays. It is obsolete tests. Obsolete test means it is generally not used these days. This test is majorly replaced by more effective test or less invasive tests. So lactose H2 breed test. Lactulose, lactose H2 breed test. Done in lactase deficiency, they will feed the patient with lactose. If he is suffering from lactase deficiency, the patient will produce H2 gas. If we diagnose that the H2 gas is more than 20 ppm inside the breaths of the person, we will tell that okay, he is suffering with lactose intolerance. There is lactase deficiency inside this patient. Then there is lactulose H2 breed test. What is the difference between this? The okay, I'll tell you. Lactulose H2 breed test. The metabolism in large intestine and it will also produce H2 gas, but the H2 gas will be produced within 19 minutes. Within 19 minutes. If it is produced after 19 minutes, okay, it is normal. But if the peak is there within 19 minutes, we can say that okay, he is lactulose positive. There might be large number of bacteria inside the intestine, and we will tell that short intestinal bacterial overgrowth is there. So what will we prescribe here? We will prescribe antibiotics like penicillin, amoxicillin, clarithromycin, this type of antibiotics. The difference between lactulose test and lactose test is this lactose can get digested in normal physiological conditions, but this lactulose is never digested. It should get excreted out, but still it is getting digested because of this bacteria. So that is the only difference in these two tests, or you might get confused inside these two tests. Yes, obsolete tests for malabsorption. Obsolete tests, it means that these tests are now irrelevant. They are not used. This acid statocrate test. This acid statocrate test, what is happening in this test? This is just a copy of that fecal fat test, 72-hour fecal fat test. It is just a copy. Then there is C14 trialine break test. C14 is the isotope of carbon. This is radioactive isotope. So it is marked with fats. This carbon pattern is marked with fat and fed inside the human body. Now the human will release CO2, but the CO2, and generally we are releasing CO2 only, but the CO2 released by this person will be C14. The carbon present in that CO2 will be C14. So you can identify, okay, there is malabsorption of fat inside this. So there is no need to remember this test because they are obsolete tests. No one will ask you about these tests, but still have giving you the general knowledge. The C13 tag white bridge test, same as C14, but this is non-radioactive carbon atom, and that was the radioactive carbon atom. Because this is radioactive C14, majority of doctors will only do this in emergency cases. If they require the perfect diagnosis, then only they will do this test, or else they also won't touch this test. Note: stool elastase and chymotrypsin. These are pancreatic insufficiency. If the pancreatic enzymes are insufficient, we will see in stool the elastase and chymotrypsin. Fecal alpha-1 antitrypsin, this is primary intestinal lymphangiectasia. In previous lecture, we have discussed this. And disease due to a disease which we can diagnose by biopsy are Whipple's disease, A gamma globulinemia, A beta lipoproteinemia. We will see this disease further. And this near infrared reflected analyzer. In this, we will give the infrareds and we will find that how many fat molecules are there, what is the structure of fat molecules present inside the stool. This is all about the tests, and last test remaining here is Schelling's test. What is Schelling's test? Schelling's test is also generally not used these days, but it is still important. You should know this test. 1000 microgram of unlabeled vitamin B12. This test is generally used to identify what is the reason of malabsorption of vitamin B12. Why the vitamin B12 is not getting absorbed. There are four reasons why the vitamin B12 is not getting absorbed. I will tell you. It's intrinsic factor, antibiotics, pancreatic enzymes, and if these all tests are getting false, so you will tell that the person is suffering with celiac disease. So these are the only four reasons that you can say the patient is suffering with B12 malabsorption, and the Ship's test is positive or negative. So first of all, in first phase, there are two phases in this Ship's test. In first phase, what you will do, you will first saturate the whole cells by giving 1000 microgram of unlabeled vitamin B12, and it will get stored inside the cells, and the cells will be saturated. Now what you will do? You will give 1 microgram of oral radioactive vitamin B12. Okay. After saturation, you give orally vitamin B12, radioactive vitamin B12. After you will check the vitamin B12 levels in urine. If it is less than 7%, it is the test is positive and there is malabsorption of vitamin B12. You got to know the diagnosis. If it is 7 to 10%, okay, then it is normal. But if it is less than 7%, you can tell that okay, it is malabsorption. So we will move on to the phase 2 of Schilling's test. In phase 2 of Schilling's test, there will be administration of other substances along with the vitamin B12, which is radioactive. So intrinsic factor, we will administrate radioactive vitamin B12 along with the intrinsic factor. If the percentage of vitamin B12 inside the urine is more than 10%, more than 10, so we will say that the patient is normal. But if he is suffering less than 7%, so we can say he has pernicious anemia. So why intrinsic factor? We gave intrinsic factor because we thought that the malabsorption might have caused due to the loss of intrinsic factor. The intrinsic factors are important for the absorption of vitamin B12. But if we get more than 10% inside the urine, we will say, okay, the patient is normal. If we will get less than 7%, he is suffering with pernicious anemia. Likewise, we will do same with the antibiotics. We will give antibiotics along with the vitamin B12, which is radioactive. If it is more than 10%, we will say, okay, the patient is normal. If it is less than 7%, we will tell that the patient is suffering with SIBO. There are a lot of bacteria inside the gut. We will give this with pancreatic enzymes. If it is more than 10%, we will tell that, okay, the patient is normal. If it is less than 7%, we will say the patient is suffering with chronic pancreatitis because the pancreatic enzymes are absent here. That is the only reason we can say that the percentage of B12 inside the urine got less than 7. And if these three tests you got that the percentage is less than 7, and they are all are normal, so you should finally say that okay, the person is suffering with celiac diseases. If the patient is suffering with celiac diseases, these three tests will get normal, and you will get to know that the person has celiac diseases. And that's all about today's lecture. I hope you liked it.
Free audio post production by alphonic.com.